as long, don't worry. All right, so let's talk some ear, nose, and throat. So if we don't often kind of think about ear, nose, and throat stuff, I think this is my primary care, urgent care type thing. We see a lot of stuff. So, and most of it, honestly, is the kind of common complaints. You know, people with colds, you know, think they're dying from their man cold. So they're conjunctivitis, and think, you know, they've got leprosy in their eye. Or, you know, people's imaginations and Google has not helped us at all. So you see some styes, you know, that kind of stuff. So, all right. So, but we're going to kind of talk about some of the true ENT emergencies. Okay. This is not an inclusive list by any means, but just kind of some of the things to kind of point out here. So let's talk about some nosebleeds, okay? So you got the two types, posterior and anterior. I'm sure you've heard this before. So this posterior is more rare, but man, this is a lot of bleeding, okay? And it's coming out of their mouth. It's, you know, pretty scary, to be honest with you. So this is one of those times where you just kind of have to kind of go up here a little bit and get some stuff done. So easiest way, you grab a Foley catheter, okay? That's something that you normally use for, you know, for catheterization for urine and stuff. You just throw it down the back of the nose there, throw it through the nose. Whichever, if you can figure out which side it's coming from, great, do that. But you may not be able to have a chance to do that. You blow it up, pull it, put a clamp on the nose, and then you go running and calling your ENT doc. While you're, you know, monitoring the pulse and checking. And so anterior, way more common. This is, you know, our bread and butter. See this way more times. So you've got to, you know, from the Kesselbeck's plexus, you know, that's the test question thing right there, you know. So nasal pinching, ice, these kinds of things. And people will say that they tried these at home. They haven't tried this stuff. It only went like this for like 2 seconds, and then it came in, right? So fortunately, some patients have had have some extra reasons to be having bleeding from the nose. They've just had nasal surgery. They've had they're on blood thinners. They are hypertensive. They're hypertensive and on blood thinners. And they're nose pickers. So they're just like asking for it. And so I don't know why I can't get it under control, doctor. So, and so, you know, trying the pinching, so we actually have pinchers that we give people so they don't have to hold their hand on their nose for any period of time. We want people to be uncomfortable. So, yeah, little things like this. So we'll pass these around so you can kind of, I don't know how many noses has been on, so I don't know if you want to try it or not. So you kind of get in there and then you kind of put those things on, you get them ice pack, those things, see if you can kind of stave this off a little bit, all right? We use a lot of phenylephrine spray, so neosynephrine, those kinds of things. These work really pretty well because it kind of constricts and it closes things up, so the vasoconstrictive properties to it. So the thing that most people, the rookie mistakes on this kind of stuff with the nosebleeds is that we don't get all the junk that's out in there. Because if the nose has been bleeding for a minute of time, it's going to start to clot in there. And they think, oh, clots are good, we want clots. Clots aren't bleeding, those are nice and safe. But if you're not actually going to stop it, you're just going to keep bleeding underneath there until you can kind of get it closed off. So you got to just get that stuff out. So you got to have a good blow, and this is disgusting. It comes out in these big, huge, you know, you're like, how did you have all that in there? And these big, clumpy clots, and it's gross. But you got to get it out of there. And then you can use something like this. And especially like these small nostrils, you can get in there, kind of open them up, and kind of spread and kind of sieve the area, and get some light in there, and show what's going on, and see if you can see the area that's bleeding, that kind of stuff. And then you can spray some phenylephrine spray up there, close and pinch it off again, and see if we can get it to stop. You can use silver nitrate sticks. And this one you want to definitely make sure you can see the actual little bleeder. Okay. Excuse me. So you just want to be poking the silver nitrate sticks in there, and you don't want to apply pressure for very long because you can go through the septum. So that will be that. And then your rhino rocket is kind of your last resort. So, okay, I'll pass these around. You guys can play with those. Again, don't know how many noses it's been. So.
Do you think that on both sides at the same time, or that's
You can do that on one side. I mean, if you most of these things are coming from one side. And so occasionally it's both, but if it's both, it's usually because they've had some kind of surgery or something that's causing trauma. So, do we have like a class president? Who is it? Oh, she's not here. Who's the vice president then? Uh-oh. So, I mean, we gotta have a volunteer for the Rhino Rocket. So. I think you're good. Okay. Well, that's fine. Nobody wants to try it?
Yeah, go for it.
I'll do it.
You'll do it?
So good.
Yeah, just right here.
All right.
So,
Oh, no, just stuff on the
clarification.
Then you go, okay. Oh,
All right.
that's
So this little packet here is a Rhino Rocket. It's basically kind of like some kind of little tampon device, right? And so we're going to put this in. What's your name?
Nathan.
Nathan knows here. Okay. So basically what it kind of looks like is it's just kind of got this little thing here, and it's got a little thing like a catheter or something would have. And so it's got some air stuff in there, and so we can pump it up and kind of put some pressure on these areas. Okay? Pump it up. Just like your Nike Airs back in the day. You ever have some Nike pumps, your Reebok pumps?
Yeah, I did, yeah.
There you go. Do that to your nose. And so you want to get it wet. Okay, so this is just some saline. So that's just good. Just going to soak it a little bit, some nice water in there. Brought some gloves to use. Which side do you want?
Right, either right.
The right side, okay, good choice.
Actually, it doesn't matter. A little easier.
And so this is definitely the small size, probably, honestly, a little bit small for him, so we're not doing anything too crazy. So there's different sizes. There's ones that claim they're posterior packs and they're really long. They don't really actually work on the posterior stuff very well anyway. So okay, we got your stuff there ready. Okay, all right. Just gonna hold one here.
Yeah.
All right, just gonna tilt your head up. And so we're just gonna kind of aim this thing back up into his brain, okay? Going down, because remember the nose isn't up, it's back, okay? Gotcha. All right, you're just going to kind of breathe in slightly. And you're going to feel pressure. There you go. And it's in. And for his sake, we're not going to blow it up. Because it feels okay? Most people, he's got his eyes watering a little bit here, that kind of stuff.
Number 1 to 10.
You want to snap a picture of it? We got to get a picture of it. So you getting good?
Oh, I got like 10 already.
It's ready.
It's ready for Halloween. Anyway, you just tape this to their nose here or their face so it stays out of the way. It's really a classic look, okay? And then they'll come back in a couple days or go see an ENT doctor, and then they'll kind of take it out. So you're going to get ready, get your towels there ready, and then you're just going to kind of blow, 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 blow. Good. Okay. All right. See, show and tell's fun, isn't it? Oh, we should have passed it around. You okay?
Yeah, that's good.
Okay. That's not good. I'm a weird guy. All right. So this is like from a picture from something, I don't know where I got it, internet, so kind of the same thing. We don't ever wrap anything when we do the Foley thing. We just kind of do it real quick and pull. We're not trying to get it there for very long. We're just trying to pull it up there and plot something off and hopefully get some ENT doctors over there quickly. And they'll take them and, take them to the OR and kind of put a little scope in there and find the bleeder and zap it and cauterize it. So, yes?
Do you have to pull it further out and clamp the other end then to be able to inflate it?
No. So I just kind of push it through as much as you can, and then inflate it either with saline or air. Saline works better because it kind of gives a little more weight to it. And then So they're kind of gagging a little bit when this is happening. So this is not a fun process for anybody involved. And so, but then it's real quick. So you're putting it down, squirting some stuff in there, yanking back until it comes out, and then you meet some resistance. And then I just take right here at the nose, I put hemostats. It just sits there. So, and then, towels and that kind of stuff, because there's still some bleeding. Okay? That's always fun. So angioedema, okay? We get a lot of this, or people that think they're having this a lot. We think that most of the time it's usually from their ACE inhibitors, okay? Occasionally an ARB, but most of them are ACE inhibitors. So some people have hereditary angioedema, and those people kind of know about it already usually. So the biggest thing is their airway. You got to maintain their airway. So it's all about airway, airway, airway. Okay. You're going to try steroids. You're going to try Benadryl, Pepcid, Epi. It's not going to work, but you got to give it the old college try, right? So do that. These people need to be admitted, watched. Okay. Some people won't want to stay, but you should probably do that. If they have any airway compromise, need to be intubated, or if they're really bad, and be working with your doc to talk about a crike, or call somebody to get a trach or something like that. So this can be bad. So looking out for that. So they're going to come in with swollen lips, that kind of stuff, and they're going to come in pretty quickly because this it looks weird. So they wake up like this. You don't know the duration of time. Is this just starting? Is it going to get worse? So things you're going to be looking out for to see if they're going to need airway, or one, if they're having trouble breathing, are they not getting enough oxygen? Are they hypoxic? Are they going to be not maintaining their secretions, or their big thick tongue hanging out and it's just drooling? Maybe a sign that we need to sedate them and ventilate them. So most people though, they kind of get to a certain point, and they just need to be watched and admitted and overnight and kind of kept safe, monitored, and that stuff. Okay. So the hereditary angioedema, C1 esterase dysfunction. Okay. So this is if you have some minor trauma, dental procedures, their grandson kicks them in the face or something like that by accident, and this can kind of spur this on. Same picture. You can try all this medicine, and it might have a little bit mild symptomatic relief, but again, it's just protecting the airway and the body. Sometimes they get immunoglobulin therapy and they can start from the patient. Questions on angioedema? It's not as much fun as nose stuff, is it? Unless you want to, do a crank on somebody up here. All right, dental stuff. People are always continually shocked. Shadows, new writers, whatever, come in. There's a dental pain. Why is somebody here for dental pain? Why don't you go to a dentist? What are some reasons why you think people don't go to the dentist?
Insurance.
What's that?
By appointment, they have to pay.
Right, okay, so it's by appointment, it's hard to get in. They don't have dental insurance, okay?
After.
It's after hours, okay? Yeah, all these things are barriers to it. Dentists are expensive, they want money up front. People don't have money up front, so the few places that do provide payment plans and that kind of stuff, usually you gotta have credit to do that. People don't have credit, and so and then we have some low-cost places here in the city and stuff, and we like to give the resources to those, but oftentimes they're always booked, and so it can be months before they can get in, or sometimes they have to wait until they do some special things down at the convention centers. They'll do a bunch of dental things like that, or they'll have a dental truck come in by the rescue mission or something like that. So those are just some barriers, reasons why we see them. So obviously, people have poor oral hygiene. If you have little economic stuff, this is going to be about, am I going to buy food, or am I going to buy a toothbrush and toothpaste? Obviously, I'm going to buy food, right? So, or drugs, or do tattoos, or do cell phones, or nails. So, not everybody makes good decisions. It's okay. So, smoking, substance abuse, diabetes, all these kinds of things are things that we kind of look out for a little bit. Definitely think so. Most infections involve the dental pulp there. There's tenderness the tooth, the surrounding gingiva, there's erythema, it's kind of edematous, okay? These are polymicrobial, there's bugs that are in our mouth, okay? So there's a good picture, little abscess there, that's a nice one. Occasionally we lance these things, usually it's gotta be something that looks like that, or I'm poking a hole in anything, but most of the time it's just treatment with antibiotics and trying to get them to follow up. So, antibiotics, so penicillin bases, you know, they're cheap, they're easy to get, a lot of people have allergies to them, unfortunately. So, next line is some clindamycin, works pretty well, a little more expensive, so sometimes I'll try and, sometimes we get the medicine for them, or I'll print off a GoodRx coupon or something like that for them to help them afford it. Most I don't, ENTs people, sometimes we consult them with some of these things. A lot of ear, nose, and throat people don't have anything with teeth, don't have anything to do with it. And so a lot of them say, well, I'm not you know, certified in oral maxillofacial, you know, this, that, and the other, and that kind of stuff. It's kind of a pawn. They don't want to deal with it because it doesn't pay well. So, you know, if you didn't go to school to do that, I guess that's fine. But, so, you know, it's pretty easy to have bad teeth, and I don't say easy, but it's taking some time. Once you have it, it's pretty easy to looking around like, oh God, that was awful. And so it's pretty common for drug seekers to come in looking for narcotics this way. And so luckily, you know, we look these people up a lot more, and we share records with other hospitals now, so it's a little easier to kind of let these people out. But you know, you look in somebody's mouth and be easily kind of fooled. So I'm a big believer in dental blocks. So I'll give somebody a dental block. I've had a bad you know, toothache where I needed a root canal, that kind of stuff. It hurts. You know, you start where you take some ibuprofen and 30 minutes later your pain's back. You know, you're like, I need something done. And so the truth is that narcotics and that probably aren't going to provide a whole lot of relief for this kind of pain. Okay, and so I'll do some dental blocks to kind of get them the easy relief a little bit. It's easy to do here in the ER. So with some just a sample. There's many dental blocks. So the three we'll kind of talk about are the most common ones. So the infraorbital block, okay, so you have these nerves that come out right from underneath the eyes, and they come down, they cover the lips, the front gingiva, and the front teeth. Okay. That's also an important one if somebody trips and falls and knocks out the front tooth. It's good to numb them up there too. So you can do both sides if you want, if you're not sure which side it's on, but usually it's right in the midline. So and you're just kind of pulling back. Here, I think we got some pictures. So you're infraorbital there. So pull back. Nobody has a retraction like that. So tongue depressor, just pull their lip back and stuff. You're just aiming kind of towards their pupil a little bit. You're going pretty deep, so the first few times it's kind of scary. Injecting a few cc's of lidocaine and different things. So I mean, Marcaine or those kind of things. I avoid any epinephrine products and these things just because, you know, I don't know where I'm aiming. I'm aspirating, but you know, I don't have the cool aspirating things. So it's a little more janky version of it. So I don't use a lot of epi. And I've had a bad experience with a dentist using epi and trying to kill me. So I'm lying there getting a tooth. It's an oral surgeon really, and we'd actually already joked about you know, the epi a little bit on the previous visit, and so I'm sitting there, and all of a sudden I start feeling this, my heart starts to race, clammy sensation all over me, and this impending doom situation, kind of feeling like your chest is caving in. Yeah, that's about what it feels like. He's like, and I kind of make this like, sound because I got these blocks in my mouth and stuff. He's like, I'll be done in a minute, thinking like, you know, he's just causing me pain. And then he's like, oh, you don't look too good. And then they like hook me up to the monitor and my friends. But then he's teasing me, of course, now you know what your patients with get epi feel like. Thanks. So that's it for orbital. Anyway, so mental blocks or submental blocks, okay, these are down here. So these are going to cover your lower lip, your lower gingiva, and your teeth, okay? They're easy to do as well. Just pull the lip back, kind of aim, dart, aspirate, and squirt. Not very hard to do this. So pretty easy to do, especially if you get some, somebody's got some front teeth damage there. Pretty easy one, okay? So the inferior alveolar is a little bit harder. Takes a little bit more practice with this. This is probably a more common one. Your lower dentitions, often the most common, and the molar area is most common to be affected. More problems with that than others, okay? The tops are really hard to numb up. There's your superior posterior alveolar nerve up there, and it's a elusive little devil. And so sometimes you have to do a few pokes, okay? And so on this guy here, so he's getting, where's that big stick? I assume it's a he because of the 5 o'clock shadow. So, good lady. So we're aiming right back here, so you get this kind of, it's hard for me to see, but you kind of got this ridge here, all right, and then you kind of get this little hump, and it's kind of right in there, right in the right spot. What I do is I kind of get in there, aspirate, of course, because I don't want to kill anybody, and then I inject my lidocaine in there, and then sometimes it doesn't work, okay? And so to cover my butt a little bit, what I do is your long buccal nerve runs right through here, and so I'll do a second stick, do a little buccal block right there, and those are really easy to get, and so somebody can at least get some kind of numbing sensation. That way when you go back to it, that's starting to kick in now? He's never asked anybody if they're better yet. That's starting to kick in yet? Yeah, it's starting to numb up. Great, excellent. I'll see you, bye. Nice to meet you. So, always gotta have some tricks. Tricks up your sleeve here. So, I like them, they're easy to do. They take, 2 minutes to do, pretty safe, really. And so, if they're easy, you can give people a lot of pain. So, and plus, if they start getting needle phobic all of a sudden, you get those tattoos and different things that maybe you just for drugs. Here's your naproxen. Enjoy. So, the main true dental emergency is actually Ludwig's angina. Okay, doesn't sound anything like anything that has to do with teeth or anything like that. It sounds like classical music and chest pain. But so I don't know who Ludwig was, but he came up with this. So it's potentially life-threatening. So it involves the dental pulp. Again, it kind of creates some submandibular edema, an infection there, and so it pushes everything up, pushes the airway back, causes drooling, trismus can't open their mouth, so now you get drinking, so it's worse and worse and worse. And start to see it on the neck even, okay. Sometimes these people will actually need some airway management, so, but gotta get the infection under control. That picture on the left is the sublingual edema. You can see that kind of area kind of popping up close, higher than the teeth. That's not a good sign. And something just for documentation purposes, when we see somebody with dental pain, every time I look in their mouth, I'm always documenting in there that they didn't have a normal dental pain patient. They didn't have a sublingual edema, and they didn't have any edema or erythema to the neck. Questions on that? Okay. So don't come to me if you have a sore throat, because I'm going to find your peritonsillar abscess. Okay? I don't know what it is about me, but I will find it. If you come in, you may come in and think, oh, it's just a sore throat. By the time I start asking questions, now we're doing some workup on you. So it's often just triage of sore throat, so pretty common for PA surgical practitioners in an urgent care setting or ER to see these patients, okay? And so, when you're talking to them, initially it should be a sore throat, I don't feel well, it hurts to swallow, it hurts to, do this and that and the other, can't drink anything, it hurts to swallow medicine, and it seems like a normal sore throat, they ache all over, like a strep throat or something would, even they might tell you, oh, it's real swollen back there, my tonsils are really swollen, I looked in there, that kind of stuff, and then you ask, does it hurt on one side or the other? They're like, yeah, it is a little bit more on the left side over there, okay. Then you look in their mouth and it looks like this. And so you can see how that is all kind of pushed over there and more swollen there on the left side. And so, as you're like, yeah. And so sometimes you get kind of pushing over the uvula there. Okay. So this is a CT image. The arrows have conveniently told you where the abscess is, so that blackness right there, you don't want to see that, okay? So, kind of the workup for it, probably gonna need some blood work, so you want to see if they have a white blood cell count that's really high. You know, the BMP, I mean, it's not totally necessary, but a lot of places will make you get some kidney function stuff on somebody, whether you're doing a contrast study or CT, so if you're gonna use some contrast, I want to make sure they're not gonna send them into acute tubular necrosis or something, so you're gonna consult ENT. Sometimes these things can be drained, okay, sometimes they can be managed outpatient, you know, kind of depends on the patient a little bit. You know, are they gonna be easy to follow up with? Are they, you know, living on the streets? Or are they living in a mission? You know, these kind of things you're gonna have to take into account when you're looking at some of this stuff, so. But the medical kind of management of it is, you know, get some fluids, because they're going to be dehydrated sometimes, IV steroids, high dose steroids. So I'll do, you know, 10 to 12 milligrams of Decadron, IV every 4 hours, you know, large dose steroids for a little bit. IV antibiotics, clindamycin, Zosyn, these kinds of things, salt or gargles. You know, ENT doctors really love these things. I guess it helps kind of open things up and helps things drain a little bit. Sometimes if you just kind of can get a hole in it, it can help keep them from having a surgery. So we'll watch a little video here. Oh, you're gonna be like this, huh? Let's see. I'm not gonna trust Internet Explorer. I'm gonna go Chrome. Kind of spraying some topical kind of numbing spray in there, some Cetacane or something like that. A little numbing medicine, so kind of noticing a blanching there. That's lidocaine or whatever he's using going in there. Really nice and numb there. Really want to make sure it's not. So look after it. So they're using kind of a big 18 gauge or something like that. I'm going to try and aspirate this abscess here. Very nothing pretty deep. See all that fluid kind of going in there?
Cool, that's gross.
So that's all what we'll do in the emergency room is just going to aspirate it. And so the next step is I think he's going to cut it or something like that. Oh, he's going to aspirate it one more time. So that's that. So, oh, I hit the mother load there. Look at all that. Yeah.
Holy shit. That to hurt. Yeah.
Well, that's got to feel better already.
Yeah.
So, we don't have a Landsat, so that's like ENT. All right, so, and we will do some of this stuff in the ER, you know, it kind of depends on the comfortability of, you know, the supervising doc and stuff, but we will do something like this, so. The kind of way we do it is, I'll have, so somebody will take a laryngoscope, so somebody that you use like to intubate somebody with, and so it's got a nice light on it, it's got a nice little blade, and I actually have the patient hold that, and they'll hold down their tongue, because they know where their gag points are. They'll pull it down as much as they need to, and sometimes have to coach them a little bit. Like, all right, just a little bit more, we need a little bit more on the left side there. And then kind of use that, got a nice light source in there. try to open them up as much as you can, squirt some of that spray, and then it's gonna follow that video, except for the scalpel. And then you just get a hole in there and get something draining. That's gonna be help this thing resolve a lot quicker. So if you don't get a whole ton, at least you're starting. So it's kind of fun. Questions on that?
Do you ever have like water dry upset from swallowing?
I'm sure they do.
That's nice.
That doesn't sound like I think I would. So, you also want to have suction there. I didn't show that in there, but I'd have some suction to kind of suction out the mouth. Those kind of gross things. Hopefully we can catch some of this stuff before it swallows down. And then saltwater gargles. Gargle away. Okay, so then the retropharyngeal abscess. This is another life-threatening one. So peritonsil abscess can be life-threatening, especially if they have like some underlying sleep apnea or something like that. You get a lot of pressure. They sleep on one side, and it's on the opposite side. It can actually kind of close off the airway a little bit. So that's very rare for it to become that way. But this one here is definitely, because it's coming from the back part there, it's pushing everything forward. You can really kind of cut off airway pretty quick. So it's going to present as a sore throat, fever, but this person's going to have some neck pain, maybe some rigidity to their neck. Okay, they're going to be talking. The classic one for the peritonsil abscess is the hot potato voice, or that raspy kind of voice, and this kind of has something similar to that. So, and kids get this kind of retropharyngeal bulge. We'll see a picture of in a second. But they almost kind of present more like somebody with meningitis or something like that. So they kind of really stiff neck and rigidity and those kinds of things. So they don't want to move your neck. So there's the up one's the bulge there. So basically the uvula is pointing right at towards you. That's not good. So, and that's a CT scan there. Retropharyngeal abscess. Anybody see it? All this blackness here and that there. That should be there. It's all pushing that airway forward there. Airway is the most important treatment. ENT consult, IV fluids, IV antibiotics. They do need to be admitted. Probably some kind of, at least a step down or intermediate care, something like that. They need to have all the prep work done to have a cryo or trach or something like that. So needs to have everything laid out, ready to go in case they need it. Some kind of difficult intubation tray or something like that. Don't miss that one. Don't look in that throat and be like, oh yeah, everything seems a little close in there. You can't move your neck. It's strep. Don't worry. I got a positive strep test. Strep tests are awful. Okay, so no place has a good one. They're all really crappy. All right, and if you can't diagnose regular strep throat by using the criteria and stuff, then you shouldn't be practicing medicine. So, all right, foreign bodies. Okay, love foreign bodies. So. PA student who's with me this month got to pull out a fun thing from an ear the other day. It wasn't that fun, it was like an earbud piece that had fallen in there. It's been there for like a month, and so they're like wax over it. Just made water. It was fun. It's kind of rewarding to pull something out. I'm like, yes, I did it. Oftentimes there's not a whole lot of like job satisfaction of what you do. You send somebody home with some scripts for their pneumonia or whatever. You don't get to see if they're better, right? You get to pull something out of somebody's ear and like, yes, I got your cockroach. Oh, and you have another one. So it's never fun when somebody presents the ER or something in their ear. You find the one bug that's in there, and then you pull that one out. And you're like, I think there's still something. Oh, you have an old one in there. That's gross. So bugs crawl into the ears and the nose. Especially this time of year is pretty common because it's getting a little chilly out, and those bugs that have been sleeping with you in your bed decide they want a little warmer place to go, so they go into your ears. People swallow things, stuff into things, go into eyes. Alright, so ear, foreign body, bugs are most common in adults, kids put things, beads and all kinds of stuff in there, alright? So we got some tools of the trade here to kind of get these things out, so, these are alligator forceps, or, I refer to them as bug getters, okay? So, these work really well. And then we have like a curette, you guys have seen these, just pass quickly if you haven't. So those will get something that you can just kind of scrape out, scrape, okay? So for the bugs, you want to try and, if they're still alive, you want to kill them. Use a little lidocaine, lie on the top of the side, so if you drops in the air, it'll kill the bug. So lidocaine works for everything, doesn't it? So the cockroaches, the legs, the previous picture. So those legs have those little spiny things. Those legs like to stick to the TM, so you gotta make sure you get those out. So, I've seen a tick on a TM before. Yeah. I was like, I don't know what to do with this. Call your nose and throat doctor on this one, because I'm not touching that thing, so. Sometimes you can use these alligator forceps, you have the patient lay on the unaffected side, trying to keep them as calm as you can. You want to avoid, rubbing that thing on the base of the ear, because that's the most sensitive part of the nerve is, right? So on the top or something like that. Trying to grab that piece and pull it out. So it's a difficult kind of procedure sometimes, because you're, trying to look at the light, and there's not enough room for the light and your forceps and to look and see at the same time, so you're kind of going in blind sometimes. You want to be digging around a whole lot. Suction works really well. Little plastic pieces of hearing aids, little plastic pieces, things that kids might put in there. You can get there's like pediatric suction things that work. Some of them are kind of fenestrated on the end, so you have to cut that off. But just low suction, put a little lidocaine or some fluid in the ear, and then you just kind of stuck in there, and usually it comes right up. Look like a rock star. So if you can't get it, then give it a few tries, see if somebody else can grab it. If not, then send them to an ear, nose, and throat doctor. You're not going to die with something in their ear. As long as you kill the bug, at least that's half the battle. You need to get it out, but I can say that. Nose, foreign body is my favorite. Screw up the nose. This actually wasn't all that deep, and I really didn't need to get an X-ray, but I figured the picture was pretty cool, so I went and did it. So one thing with the nose, most, some kids you can coach to do a good blow. Little kids, you can have them all kind of blow and try and blow some, see if they'll blow some stuff out. Sometimes I do that. So I had a kid that was went to an urgent care first. They had stuffed like the foil packets to like the gum wrappers like up his nose. And so there was urgent care. They're like, oh my God, we can't get it. They tried, and the kids squirmed and all kind of stuff. And I was just asking, I'm assuming you guys have, had to try to blow his nose and that kind of stuff. And they just kind of looked at me like, no. So we had a kid, all right, snot rocket the stuff and showed them to do it. Right out. Like, all right, that's all we need to do. So we have to go digging around, getting it down. But occasionally you got to go dig something out. This little device is called a CATS extractor. There's other names, but basically what it is a little catheter tubing, and it's got a little balloon on the end. This one's kind of old, so it doesn't blow up as well. But and so basically what you do is you insert it past the object, inflate, and then pull it out. And so we're scraping ears, noses, and that kind of stuff. So we'll pass it around. And you got to be really careful with magnets. So, of course, it gets swallowing magnets. We've all heard those dangers, especially two of them. And they can attach to each other and cause some obstruction, those kinds of things. But in the nose, in a place like that, especially if there's one on either side of the septum, it can be very dangerous. So, and the kid coming with two of those little powerful magnets on his nose, and I tried to get them off. I tried to use like, big piece of metal and try and get it to stick to that, and it wouldn't come apart. I called the ear, nose, and throat doctors, and I'm thinking that he's going to yell at me for being unsuccessful about hitting these, and he's like, oh, good, God, glad you didn't take it off. Because what usually happens is they'll get some hemorrhage after you move it, And so they said that the last time they took him off in the OR, they had all this bleeding and it was really hard to control. So I was really glad I did not take that off of the old fast track. So I-form bodies, so grinding people who are grinding in metal, woodwork, that kind of stuff. Most common, but you can also, people will come in saying they have something in their eye. Sometimes it's also just a scratch, so fingernail or dog or something like that has got it too. So you get a look in the eye using a slit lamp, okay? And so a lot of people are, especially our new providers, are kind of afraid of the slit lamp for some reason. I guess we just don't teach eye stuff very well in school because I was kind of scared of it too. Once you learn it, it's pretty good. And so you actually get a really good look at the eye. And stain it, see if there's any corneal abrasions or anything like that that could be causing this pain. Sometimes you can see it with your naked eye or just a little light, and that's fine. But you also want to make sure you stain it still, see if there's any other abrasions in there. And sometimes somebody will get something in their eye, they'll actually kind of roll around underneath the eyelid for a while, scratch up that cornea really well, and then finally embed into the cornea. So you can try, you always want to invert the eyelid or pull the eyelid back and look up there really well, make sure there's nothing on the bottom side of that eyelid. And then you can try like a wet Q-tip and just kind of wipe once it's numb, obviously. Barricade drops in there and stuff, so you can do that. And so, let's see, this is a strip, you can open it up and see what it looks like. This is an old one, so it's probably got a little stain on there. So these are just prepare cane drops, don't use them in your eyes. And so, then some eye stuff is irritation, that kind of stuff can be caused by gases or liquids, this kind of thing. So if you get something like that, you think that they need to get this flushed out. They already tried like an eye wash station or something like that. You can use the Morgan lens. So that's basically like these things here that are kind of like these little suction cuppy contact things. You kind of open their lids, put these things in, and attach the other side to saline and just run it through their eyes. Big basins and eyes are just running. It's not very comfortable looking, so that's what I'm into. So metal in the eye, so you get a piece of slag from welding or grinding or something like that in there. Sometimes you need to burr it out. I was initially really freaked out about doing this. This is called a burr, so it sounds like a drill. When you actually look at it, it's not a drill, it's actually a little scoop. So it's got these little kind of edges on it. And so if you just kind of apply it to it, it just kind of scoops it out. And then you can kind of, have to check for a rest ring. So if it's been in there for any significant amount of time, because of the salinity of the eye and the type of metal, it can cause a little rust ring around there. And you also need to remove that rust ring from the cornea. So basically you're scraping off this person's cornea a little bit. It's kind of fun. And you do this under a slit lamp. Okay, so you're looking through the slit lamp and aiming. It's not hard to do, but once you do it a few times, it's fine. So I've heard people try like an 18 gauge needle and get it off too. A burr seems much more cool. So definitely want to do this after they've had the drops. So, forebite in the throat. Okay, most commonly this is a 30 to 60-year-old male who has eaten meat too quickly. For some reason we're just in too big of a hurry and we can't bother to chew that meat down or savor it at all. We just want to put that thing into our belly. And so it gets stuck. Sometimes it's because people have some strictures or have some esophageal disease already. And sometimes it's just because it's just too darn big or some bristle in there and it won't go down. So there's some medical things you can try to get it to pass. So you try glucagon, which seems kind of odd, but it seems to help that go down. People will try at home, sometimes they'll try and drink meat tenderizer or something like that to try and, gross, right? To try and get it, drink soda and different things like that, hydrogen peroxide, none of that works. So try some glucagon, you can also add some Ativan to it or something like that, helps kind of relax the muscle and see if you can get it to pass. And then if it doesn't work, then you gotta call, GI to come scope them, and they'll pull it out or push it down, depending on where it's at. So, GI, they do that in our ER. They'll just bring it down, bring it up, scope down, stick it in there, sedate them, push it down, pull it out, put them on some Prilosec or some Xanax for a few days, and have follow up. Questions on that? So, and people can swallow things, so usually you gotta get that out. If they've swallowed something, I gotta make sure it's not in the airway. So, is this coin here? Is this in the airway or is this in the esophagus? How do you know? This flat, right, from that side view. Okay. Guarantee that'll be a test question. Okay. So. So got, you know, be afraid of batteries, magnets, anything sharp, pointy, that kind of stuff. I've had a pediatric ENT do for me that it will pass on its own without any disruption. That seems kind of crazy, but apparently it does. So usually, like our kiddos, because we don't have all that PED stuff at Saints, we'll send them to children's and they can get it out. So if they've actually swallowed something that's in their belly, we just want to make sure that it passes beyond the pylorus. So what you can do is kind of have them, once they've swallowed something, you see something in their belly, the coin in it, something, well, they could look like about a nickel size or something like that. And then we waited a couple hours, repeated the x-ray, and it was further down. So we realized that it had passed the pylorus, and so it seemed further down. So no further workup. They just need to go, they want to retrieve their coin, they can do that later on. So, little case study here, okay, 28-year-old guy, sore throat, 4 days, okay, seen it at urgent care. Oh, it's urgent cares. All right, place on the old Z-Pack. Don't put a person on Z-Pack for a strep throat. It's not going to work. A lot of resistance, okay. Hard to swallow, slightly more painful on the left. They're coming to see me, so what are they going to have? There you go. So, labs, all that kind of stuff. And, now, I think this is going to work. We'll try. Yeah, there's a little movie, but then the guy ended up having a peritonsillar abscess and a retropharyngeal abscess. So he had a no good bummer of a day for sure. So, all right. So he obviously got admitted. He admitted to like a step-down unit where he could monitor a little more closely. ENT was involved. Medicine was involved. He was getting antibiotics. So. Questions? All right. Well, not too bad, huh? Just a little bit over. I blame it on the monitor.
Oh, really? I'll save it for later. Oh, yeah.